Welcome to week 2 of the nephrology teaching sessions for medical students and residents. Today we're going to be talking about the principles of chronic kidney disease management. The objectives of this video are to gain a better understanding of the definition and prevalence of chronic kidney disease, to gain an approach to the management of chronic kidney disease, including slowing progression, modifying complications, and preparing and educating around renal replacement therapy. We're also going to try to understand the principles of some of the renal replacement therapy options. So let's start off with defining chronic kidney disease. So the definition from 2002 from the Kidney Disease Outcomes Quality Initiative Group, or KDOQI, defines CKD as any renal abnormality for greater than 3 months. This can be from decreased renal function, which is defined as an estimated glomerular filtration rate of less than 60 mL per minute per 1.73 meters squared, or markers of kidney damage, which can include albuminuria or other urine sediment abnormalities such as hematuria. It can also include abnormalities on histology or imaging, for example, polycystic kidney disease, and patients with a history of kidney transplant. So, what is the prevalence of CKD in Canada? There was a study in 2019 that showed that approximately 10% of the Canadian population, or 4 million people, have CKD. Approximately 0.01% of the population, or 40,000 people, have end-stage kidney disease on renal replacement therapy. The study also looked at the overall prevalence of CKD based on deprivation index, which takes into account factors like housing, income, and education. You can see in the top figure that this study showed a higher prevalence of CKD in more deprived groups, shown in the light blue and purple boxes, compared to those who are less deprived, shown in the dark blue and red boxes. The figure at the bottom shows that there is a higher prevalence of CKD in rural settings, shown in the red boxes, compared to urban, shown in the blue boxes. The incidence of CKD is also on the rise. This study in CMAJ in 1999 showed that the incidence of end-stage kidney disease was shown to increase between 1981 to 1996. It was also projected to continue to increase across all provinces in Canada into the early 2000s. So let's talk about the classification and nomenclature of CKD. This is the current nomenclature used by KDIGO. The classification is based on GFR and albuminuria. There are 5 GFR categories. Stage 1 is a GFR of greater than or equal to 90. Stage 2 is a GFR between 60 and 89. Stage 3A is a GFR between 45 and 59. Stage 3B is a GFR between 30 to 44. Stage 4 is a GFR between 15 and 29. And Stage 5 is a GFR of less than 15. There are 3 albuminuria categories. Stage 1 is albuminuria less than 3 milligrams per millimole. Stage 2 is albuminuria between 3 and 30 milligrams per millimole. And Stage 3 is albuminuria greater than 30 milligrams per millimole. The colors below show the risk of complications and future outcomes to help guide testing and treatment for CKD populations. It's recommended to assess GFR and albuminuria yearly in patients with CKD, if not more frequently in those with a higher risk of progression. And there are a number of other factors that can impact this, including cause of CKD and other factors such as age and gender. Here is a list of the most common etiologies of chronic kidney disease and end-stage kidney disease. You can see that diabetes is the most common cause of CKD or end-stage kidney disease at around 28%. This is followed by hypertension or vascular causes, glomerulonephritis, and polycystic kidney disease. Risk factors for CKD can be classified into modifiable and non-modifiable risk factors. Modifiable risk factors include diabetes, hypertension or vascular disease, smoking, medications, chronic infections, urologic diseases such as BPH and malignancy, and glomerulonephritis. Non-modifiable risk factors include age, gender, with males having a higher risk, race with a higher risk in African American and Indigenous populations, family history, and genetics. The first step in managing CKD is delaying the progression. There are a number of strategies used. Firstly is blood pressure control. and generally the blood pressure target is less than 140/90 or less than 130/80 for patients who are diabetic or have macroalbuminuria. ACE inhibitors or ARBs are first line for blood pressure control and proteinuria. In terms of proteinuria reduction, there's no evidence for dose or target reduction, but generally the aim is to reduce to less than 500 to 1,000 milligrams per day. AKI prevention is also key in delaying progression. The MDRD study also suggested that a lower protein intake to 0.8 grams per kilogram per day can also slow the progression of CKD. For diabetics, optimizing glycemic control is important, targeting a hemoglobin A1C of less than 7% when safely possible. Other things include a low salt intake at less than 2 grams per day, as well as general lifestyle measures including physical activity, smoking cessation, and maintaining a healthy BMI. The second part of managing chronic kidney disease is treating complications associated with CKD. This includes cardiovascular disease risk reduction, anemia, metabolic bone disease, acidosis, electrolyte abnormalities, volume overload, and uremia. All patients with CKD are considered at increased risk of cardiovascular disease, particularly those aged greater than 50, with a GFR below 60, or with albuminuria. In fact, patients who have a GFR between 20 and 50 have a 2.5 times higher rate of MI compared to the general population. Therefore, for cardiovascular risk reduction, KDIGO recommends a fixed-dose statin for patients whose GFR is below 60, with the standard recommended doses shown in this table here. Patients who are started on a statin can continue this as they progress and are started on dialysis. However, there's no good evidence to start a statin once a patient has already started dialysis. Let's talk about anemia of chronic kidney disease. As you know, anemia is diagnosed with a hemoglobin of less than 130 in males and 120 in females. Anemia of chronic kidney disease is a diagnosis of exclusion, and so CKD patients who develop anemia should be investigated to rule out other causes, including deficiencies of iron, folate, or vitamin B12. The mechanism of anemia of chronic kidney disease is thought to be from lower erythropoietin production due to reduced renal mass. CKD patients are screened for anemia every 3 to 12 months, depending on their KDIGO risk classification. Because CKD patients use their iron stores less effectively than others, it is recommended that IV or oral iron be used to target a transferrin saturation above 30% and ferritin above 500. Once patients are iron replete, erythropoietin stimulating agents, or ESAs, are used to target a hemoglobin between 100 to 115. ESAs need to be used cautiously in patients who have an active malignancy. And the reason why we don't target normal hemoglobins is that studies show an increased risk of stroke once ESAs are used to target a hemoglobin above 115. We'll now move on to metabolic bone disease. This is a disorder of mineral metabolism manifested by hyperphosphatemia, hypocalcemia, low activated vitamin D, and hyperparathyroidism. The kidneys are the site of major phosphate excretion, and they're also responsible for the final conversion to activated vitamin D with 1-alpha hydroxylase. The way that I think of metabolic bone disease is that as our kidneys fail to excrete phosphate, this causes the excess phosphate to bind to calcium and cause hypocalcemia. Low activated vitamin D also reduces the amount of calcium absorbed from the gut. These are all stimuli for PTH, which causes hyperparathyroidism and causes resorption of calcium and phosphate from the bone. This results in risk of vascular calcification from the precipitation of calcium phosphate products, fractures from resorption of calcium and phosphate from the bone, and cardiovascular death and all-cause mortality. Hyperphosphatemia results primarily from reduced renal excretion of phosphate. Management of this revolves primarily around a low phosphate diet. You can see from this photo that high phosphate foods include dairy products, beans and lentils, processed meats, chocolates, and dark-colored colas. The next step in management is using phosphate binders with meals to augment GI excretion of phosphate. These include calcium and non-calcium containing phosphate binders. Calcium-containing phosphate binders should be avoided in the cases of hypercalcemia, adynamic bone disease, and vascular calcification. Hypocalcemia primarily results from reduced gut absorption due to reduced activated vitamin D. To mitigate this, activated vitamin D can be prescribed. However, remember that vitamin D increases calcium and phosphate absorption from the gut, and so calcitriol needs to be used cautiously in patients who have problems with high phosphate. Hyperparathyroidism results from stimulation from hyperphosphatemia, hypocalcemia, and reduced vitamin D. Therapeutic options include calcitriol, cinacalcet, and parathyroidectomy. The target is to achieve normal calcium and phosphate for metabolic bone disease. PTH targets in patients who are pre-dialysis is not entirely clear, but for patients that are on dialysis, the general target is for a PTH 2 to 9 times the upper limit of normal. When it comes to treating osteoporosis, it's recommended that CKD patients with stage 1 or 2, as well as stage 3A or B with normal PTH are treated similarly to the general population. However, therapies need to be monitored as there is a risk of severe hypocalcemia with bisphosphonates and denosumab. Metabolic acidosis is a complication that results due to the loss of proximal tubule bicarbonate reabsorption and the lack of distal tubule bicarbonate regeneration. This can result in a vicious cycle due to the activation of endothelin-1, aldosterone, and angiotensin II that can result in inflammation, fibrosis, tubular atrophy, and proteinuria, which can further diminish kidney function. Sodium bicarbonate is used to target a bicarbonate level of greater than 22. Electrolyte abnormalities can occur due to the kidney's key role in homeostasis. The two primary electrolyte abnormalities that occur are hyponatremia due to volume overload and excess free water. The other electrolyte abnormality is hyperkalemia. Generally, the target potassium is to be less than 5. In order to achieve this, a low potassium diet is required, and you can see that there are many fruits and vegetables that are high in potassium. Diuretics can also be used to enhance the renal excretion of potassium. Medications such as NSAIDs need to be avoided. And as a reminder from the first session, the acute therapy for hyperkalemia is calcium gluconate to stabilize the myocardium, shifting with insulin, bicarbonate, and Ventolin, and excretion through the GI tract with Kexalate. Volume overload is also a complication of chronic kidney disease related to reduced excretion, and the mainstay of therapy is fluid and salt restriction as well as diuretics. Uremia may develop as the kidneys fail to excrete urea and the other toxins in the blood. Uremia can manifest as many symptoms. This includes anorexia, nausea, vomiting, weight loss, and a metallic taste in the mouth. Patients can also develop uremic pericarditis, which may not have the classic ECG findings. Other symptoms include peripheral neuropathy, pruritus, mental status changes, seizures, mood disorders, low libido, erectile dysfunction, and amenorrhea. Patients may also develop bleeding from dysfunctional uremic platelets. The photo here shows uremic frost, which is almost never seen anymore. The last part of CKD management is preparation and education around renal replacement therapy. In terms of timeline, a typical referral to nephrology is made at around a GFR of 30, as that is when complications of CKD may start to develop. Modality education and access placement is generally done around a GFR of 15 to 20, which is also when a transplant workup and referral is started. Renal replacement therapy is initiated generally at a GFR of less than or equal to 10, and/or when patients develop symptoms or an indication to start dialysis. You'll remember from session number 1 the AEIOU acronym for indications for dialysis. This also applies in CKD patients, but again, refractory to medical management. Options for renal replacement therapy include dialysis, which include either hemodialysis or peritoneal dialysis, conservative kidney management, which focuses on treating the symptoms of kidney disease, and kidney transplant. Let's briefly talk about how hemodialysis works. Hemodialysis utilizes the principles of convection and diffusion using a semi-permeable filter with countercurrent flow between blood and dialysate to correct electrolytes, clear uremic toxins, and correct acid base. The dialysate contains bicarbonate to correct metabolic acidosis and generally has a lower potassium than the patient's blood to correct hyperkalemia. You can see in this figure at the bottom the general flow of the different molecules between the blood and dialysate. The standard duration of hemodialysis is 4 hours 3 times a week, although there's also a nocturnal hemodialysis program that offers 8-hour runs 3 times a week, as well as the home hemo program, where patients can dialyze at home for as often and as long as they would like. The dialysate can be adjusted for each patient and contains bicarbonate, sodium, potassium, calcium, and magnesium. Hemodialysis requires access to the bloodstream through a central venous catheter or an arteriovenous fistula or graft that requires surgery to be created. Peritoneal dialysis utilizes the patient's own parietal peritoneum as the semi-permeable membrane. By placing dialysate that contains glucose in the peritoneal cavity, there are 3 main processes that occur between the bloodstream and dialysate. These are diffusion of molecules back and forth, ultrafiltration of fluid due to the osmotic gradient created by a high sugar-containing dialysate, and absorption. The 2 main types of peritoneal dialysis are continuous ambulatory peritoneal dialysis and continuous cycler peritoneal dialysis, also known as automated peritoneal dialysis. Continuous ambulatory peritoneal dialysis, or CAPD, is shown in the bottom left. In CAPD, patients are performing manual exchanges using a Y system, shown in the picture on the left, where they fill themselves with solution, have it dwell for 4 hours, and then empty and fill with a new solution. The reason behind 4-hour dwells is that beyond that, glucose from the dialysate is absorbed into the bloodstream, causing loss of the effective osmol driving ultrafiltration. There are a variety of dialysate bags with different concentrations of glucose, including 0.5%, which is hypoosmolar, 1.5%, which is isoosmolar, 2.5%, and 4.25%, which are hyperosmolar. During the night, CAPD patients often fill themselves with a different type of solution, called extraneal, with a concentration of 7.5%. However, this utilizes icodextran, which is a starch that is reabsorbed via the lymphatics, and therefore this solution can stay in the peritoneum for longer before it is reabsorbed. In CCPD, using the cycler, patients have extraneal in during the day, and they hook themselves up to the cycler machine at night. The cycler performs exchanges throughout the night, filling the abdomen with fluid, letting it dwell for some time, and then draining it. The dialysate for peritoneal dialysis contains sodium, lactate, and calcium. PD patients tend to lose potassium and are actually often hypokalemic. This is why PD patients and HD patients have different diets, with the PD diet being more liberal. Conservative kidney management, or CKM, is an option for patients who do not feel that dialysis is something that they would wish, as dialysis comes with its own risks and harms. It is also an option for patients who are too frail or have comorbidities that would make it difficult for them to tolerate dialysis. The priorities for CKM include managing symptoms of CKD at home and planning ahead in terms of advanced care planning and end-of-life planning. The last form of renal replacement therapy is kidney transplantation, and this is going to be discussed at session number 4, so stay tuned. As you can see, chronic kidney disease is a complex disease with a number of issues to consider. Here is an ABCD acronym that highlights some of the issues that need to be considered when seeing a patient with CKD. Acid-base status, anemia, blood pressure, cardiovascular risk reduction, diabetes, electrolytes, fluid status, metabolic bone disease, modality and access, sick day management, which addresses nephrotoxins and medications that can be high risk in AKI, and uremia. I hope this talk makes you feel more prepared for seeing your next CKD patient, and we'll see you at the next session.